afternoon. Thank you for coming to the last session of the day. So our project, Choosing Wisely Pathology at GCUH ICU. Just to give you a little bit of background, GCUH is a 750-bed tertiary hospital serving Gold Coast and Northern New South Wales. The hospital has 75% of single rooms throughout the world. Our ICU, we relocated to this ICU in 2013, and we underwent a massive transformation. We went from 14 bed equivalents to 21. We opening new services in about 2 years. So the first 6 months we opened cardiothoracics. The first year we were accredited as a level 1 trauma referral center, and the number of neurosurgical cases increased quite significantly because the neurosurgical team expanded. But that was not the main transformation. The main transformation was the amount of new staff. So we went from about 100 nurses to 200 nurses. The FTE of registrars and consultants doubled. So we have 6 new consultants within the last 2 years. And that is not just the last. The last was an ECMO. Now we are part of the ECMO retrieval service of Queensland, and we have been looking after ECMO for the last year or so. So a big change. So based on that, the executives and the leadership recognized that we needed to focus on quality. And it was a lot of things happening in the unit already, and was a lot of people working on that. However, was no a team responsible for all of them. So the first thing that we did was to create a team. With Nicki, that is here with me today, she brought the experience. She has been in the hospital for 25 years and has been working on quality for 20 years. I put my hands up to run the quality portfolio with not having much idea what I was doing, but I was very passionate and enthusiastic about that. And we identify what were we doing. We tried to put everything together under the clinical governance and quality. We get rid of things that we were not using and were not on our best benefit, and we try to look for things that we really want to embrace. And every single time that I was looking for ICU quality in Google, the Choosing Wisely campaign kept coming and coming and coming. So just to preliminary reading, what I understood is that Choosing Wisely was an invitation to have the conversation about unnecessary tests, treatment, and procedures. Just doing a little bit more of research, I found that we have a full program in Australia, and it's an initiative that brings the community together to improve the quality of healthcare through considering tests, treatments, and procedures where evidence shows that they provide no benefit or, in some cases, lead to harm. We found the principles of the campaign, and we were very excited because this is exactly what we wanted to do. So initiatives that were clinician-led, initiatives that emphasize quality of care and harm prevention, consumer and patient focus, evidence-based, multi-professional, and transparent. So we say, this is what we want to do. But most importantly, what I found was a lot of international support for the campaign. And just get real, for a new consultant with a new portfolio, it's really important to get a lot of buy-in in the first initiative that you are proposing. So the fact that we have all this international and national support of the campaign encouraged me to empower the team and to pull this through in the consultant group. So the first thing that we did was go to the Choosing Wisely campaign and look for the college 5 recommendations. Every single college in Australia has recommendations. So we look at the college, ICU college proposal along with the ANSICs, and we found that because of the time, I'm not going to be able to go through all of them, but we found that we were doing quite good in a few of them, especially number 2, 3, and 5. And we say we knew is because we have encouraged to our senior registrars to perform audits of our regular practice. So we were quite content of our performance. And the other two, we found that they were a massive undertaking, especially number 1 and number 4, and we needed a bigger multidisciplinary team involving many more units in the hospital. So we have a look at the other college, and we went to the emergency college, and we can see that most of the recommendations are pathology and radiology. The same thing with the anesthetic college. So we decided this is probably the way to go. We found this document that is choosing widely top 5 lists in critical care medicine, embraced by 4 different societies, including nurses and doctors. So we thought this is a really good idea. And we actually love the first recommendation. And we love the words that they use to form. Oops. We love the words that they use for the recommendation. So it was not an unnecessary testing word, because that may be controversial. Nicki and I, we get it much more comfortable using it because now we have a definition for it. But at the beginning, the unnecessary word may, doesn't sit quite well with a few people. So we thought that do not order diagnostic tests at regular intervals, but rather in response to a specific clinical question was the way to go. So we embraced that, and we did a lot of work to find GCUH ICU 5 things. So we decided to go with this. ABGs. We did notice that every single of our patients, regardless of they were with mechanical ventilation or not, have an ABG done anything between 4 and 6 in the morning, the same time that they will have blood gas taken. So by routine, our nurses were taking a blood gas with the routine bloods. That ABG was seen by no one, and if was necessary, when you do your round, this is an ABG that is about 3 hours old. So we decided to stop that routine, and we encourage people to send ABGs based on a clinical question. Blood cultures are urine cultures. We found that we send in urines on Mondays and Thursdays by routine. Don't ask me why, I could never understand it. But anyway, we stopped that. And with the blood cultures, I found that my registers were sending 1, 2, or 3, or 4 bottles a day for the patient that has been febrile for the last 2 or 3 days. Which, they can argue that they have a much better chance to culture the organism instead of focusing in a good technique. But anyway, we work on that. Oh my goodness. Coagulation profile. Some of you may know GCUH ICU is a rotten-based hospital throughout, from the emergency department to theater to ICU. So we actually do not use coagulation profile a lot, apart from warfarin and heparin monitoring. So they were all done in the morning with the bloods, completely unnecessary. No one was looking at those. Drug levels. My pharmacist did an audit of our drug levels, monitoring some the most important drugs in ICU, gentamicin, vancomycin, phenytoin, and she found that 65% of the levels were done in the wrong time. She found that 4% of the levels were done in people that was not having the medication. So gentamicin level in someone that never had gentamicin, phenytoin level in someone that I have no explanation. And the last one was the MRSA and the BRE, and I'm going to talk last about this one, but it's actually how everything started. So when I was doing my round, I checked everything, and I noticed that my patients, very early, my first 6 months at GCUH, my patients has 2 sets of MRSA 2 times a week and 2 sets of BRE, and I say, whoa, okay, no, this is what we do here. No, I'm pretty sure this is not what we do here. Why are you going to, expose 2 patients to 2 sets of these screening tests for no reason? And basically what happened is that we have set days for the test. So if you were admitted on Sunday, well, the set day is on Tuesday, so you get another one on Tuesday, and maybe on Thursday again. So based on all of that, we decided that this is the 5 things that we wanted to focus. Of course, we write, we make a proposal, we write our objective. As I said before, it was very important that the project was sustainable, that the project has quality and safety benefits, and a lot of words there, but essentially the message was choosing pathology tests based on clinical need. So we use strategies, many strategies, some of them very simple, some of them were just giving the nurses access to our lab, because MetaVision doesn't have your pathology on real time, especially the microbiology. So we noticed that with these new nurses, 10 nurses coming every single week from different places with different experience, they didn't have access to pathology, didn't know when the last test was sent. So we gave everyone access. So this is one of our very junior staff looking at our lab. We made sure that choosing wisely was in the orientation for nurses within the 6 months, and we made sure that the choosing wisely was added to the booklet for the novice. And these days we have automatic login. So when they log to the computer, everything will come up, so it's not an excuse. They should know when was the last test sent. We did stamps. Everyone has stamps in the unit. This is nothing new. We used to have one that has about 10 tests, and they just tick all the boxes. So I disappeared those, and I create this one that is very simple. And the junior staff actually embraced the whole change quite significantly. I do the orientation for the junior registrar, so I make sure that every 3 months I spend half an hour talking to them about choosing wisely. Unfortunately, with ICU registrars, the only time that you have them together is the day of the orientation. That will never happen again. So if you haven't informed what you really want them to do, you lost your opportunity. Then we did some posters. As you can see, we didn't have any graphic design and support. They're very rudimentary, but they did the job. We printed mini posters and we put it in front of the bedside computer on the screen. Why? Because most people spend most time looking at the screen. And we put different messages in different rooms. So what we're thinking is, if a nurse if a nurse worked 3 days and 3 nights, go to 6 different beds, it is a chance that that nurse by the end of the week actually have read it, all the message. I mean, we thought that was impossible not to read the little poster in front of the computer in a 12-hour shift. In the second 6 months, we decided to thank everyone for the great job. So we designed new posters, the same technique, saying to everyone, thank you very much, has been fantastic. You have been of great help, congratulations, this is what we have done so far, and thank you for embracing the campaign. And they work. So they were all the simple strategies. A little bit more difficulty was being part of the nurses' safety scrub in the morning. Again, this is nothing new. Everyone has safety scrubs in the morning for nurses. But we make sure that for a month in the first 6 months and for a month in the second 6 months, Nicki and I were in the morning and the afternoon handover to spend a couple of minutes talking about choosing wisely and encourage senior nurses to ask questions or to send us emails if they were unhappy with the campaign. We also make ourselves available to go to the access nurses or the team leaders meetings, and they are the most senior nurses. We create a guideline, and we create the safety scrub for doctors. So 8 in the morning, 5 minutes of quality, what happened last night, what we can do today, and choosing wisely. Okay, so we have a pathology dashboard. This was provided by us, by the Choosing Wisely campaign that Gold Coast University Hospital champion from Queensland has been the great help, and this is the way that we're going to monitor our results for the next few years. We have something like that coming from pathology every week, telling us wrong specimen, mislabeled, request incomplete, not clinically indicated. So this is another way that we can monitor. And of course, we monitor risk man, and we did not have any risk man for a year related to any kind of test. Now, our results. This is just to show you our acuity. So from the period, study period was April 2017 to April 2018, which is the arrow, and you can see that Patient days and the ventilation days were the same, so we're talking about the same population in the two periods, and we reduced pathology all specimens by 16% in the 12 months, which give us a pathology all savings of $1,000 a week. So you can see here the orange line is our admissions. They were stable through the 2 years, and you can see how the cost of the linear cost is reducing slowly but steady. We reduced our blood gas by 24% and by 33% between 4 and 6 in the morning, the routine one. We reduced our coagulation profile by 30%, and we reduced our urine test by 24%. We have a lot of limitations. It was difficult to communicate sometimes. People took the wrong message. Was on ongoing recruitment, so it was difficult to catch up with everyone. Change in management. We have 3 NAMs and 3 medical directors in the period, and it's a lot of things that we can measure, but we know actually working. Difficulties with the project, we were very, very ambitious. Next time I'm not gonna roll with 5 different things, maybe 2 or 3. And we think that we were sending a confusing message, is don't do it, think before doing it, but if you do it, please do it well and do it on time. So it's so many things happening, and I think that will confuse the junior staff. Summary is changing culture. GCUH ICU Choosing Wisely project has embraced this change, has reduced the number of routine tests, and without any adverse events. But for us, most importantly, this is the feedback from our staff. So this is the feedback from a new grad that has been in the unit for 8 months. Choosing wisely meant no routine unnecessary labs and using clinical reasoning. This is from the ICU nurse and educator, the senior one, and this one is from the medical director. So through thoughtful commitment to the less glamorous aspect of critical care, the Choosing Wisely team at the GCUH have dramatically changed our daily practice for the better. Thank you very much.